We will continue downstream, go down to the more distal aorta is the complex EVAR. How I do it, Dr. Kiattisak Hongku from Sirat Hospital. Dr. Kiattisak yesterday also shared with us a few topics and showing some quite difficult cases too. This morning, Dr. Kiattisak will share with us some complex EVAR cases and how he managed it. Dr. Kiattisak, please.
Thank you. Good morning, Professor and Dr. Bumasit and also Dr. Chanapong and all our ladies and gentlemen. Thanks, Medtronic, for allowing me to share my point of view to treat all these patients. This is my disclosure. I just want to express my way that I see and I manage all this case. So when talking about complex EVAR, we are treating complex triple A's and also part of the thoracoabdominals that we have to cover the visual segment, maybe up to the arch and maybe up to the zone 3, zone 2. And I would like to walk through the step of planning, patient preparation, implantation, and surveillance. So the first thing, when we do the plannings for the patients, so I think we have to look at the extent and the components of the complex repair. The 4 things that I always mention about: the proximal sealing, the distal sealing, the access, and also the visual segment incorporations. That will be incorporated by many device technologies. And I think one of the most important things to choose the right strategy, to use the proper strategy that not only proper to the patient, but are proper to your facilities, your experience that you have to select for the patients. For me, I will start with the custom-made device. I will then follow with the off-the-shelf, and then another relative less common procedure like PMAX or P-branching of the parallel graft. So when we are talking about the planning, so I think if you face a patient with a young patient, fit patients, and also with some struggle to do the complex EVAR, just think back. This patient really need this complex procedure or not, or just the patient can perform the open surgery or not, and then choose the right thing for the patients. If we try or we agree to go ahead with the complex EVAR, just thinking that the overall disease burden for the patient given in the context of the patient status. Also look at the extent of the disease that we really need the treatment that indicate for the treatment, and the extent that achieve the successful repair. That means the disease segment can be treated separately or in step fashions, and then look at the extent that achieve the durable repair. Look at this scan. We can possibly see a little bit lower. It's possible to get the seal in the short term, but it's durable or not, or we need to go a bit higher to get the durable repair. But the question is, we know that the durability is a key, but how long that to be considered as durable enough? I think it depends on the patient age. The ethnic disease burdens, the comorbidities, and also the life expectancy of the patients. To my answer, it would be that as long as the repair can prevent aneurysm-related mortality for the patient, given the patient lifespan, that should be durable enough. And even the repair fail, it should be fail well, and should be some solution to fix that problem in a relatively less complicated way. Also, we have to and consider that the operative risk of the index procedure itself, not only by the regulator, it should be only in our hand too, because we cannot do something like very fancy and get the bad result as in the literature. So we have to think about that issue too. In these patients, we think that this is durable enough for the patient, but just 10 months later, the patient needs a proximal repair. So it not always as we expected, but sometimes we have to prepare for a little bit faster reintervention than we think. In these 2 patients, the patient underwent open repair, and then the patient survived long enough to get the proximal disease. So we have to get the proximal repair. And if we think about the future, if we have to repair this patient in the future, how to do it in the easy way. So we get 2-3 stents for the proximal overlap in the future. In this patient, we think about this is 87-year-old male with a relatively short neck, with the small renal arteries. If this patient is a little bit younger than this, so if the patient young, we get for sure open repair. If younger than this, probably get with some more durable repair for the patient with a complex device. But if you have some difficult issue like small renal arteries, angulation, blah, 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 that's not suitable for the complex device, just moving back and looking at the more simple options. In this patient, I do with a simple EVAR with ESAR to get durable repair enough for 87-year-old patients. For distal repair, I think for my answer, you should go as far as needs to get the durable distal repair, especially with the low threshold for the hypogastric artery preservation, because you go up there in the high thoracic region, so you may risk the patient for spinal cord complications. So this is very important thing to preserve the hypogastric artery. So with the planning, when you get the appropriate planning, you should answer some questions. You have to understand the whole step of the procedure. I think when we looking back when we are residents, so we have to do some oral surgery. So we have to walk through that step of the procedures. That means you are doing completely planning process, and you have to depict the potential problem that could happen during the procedures. For each plan, and you have to make the decision whether to modify the plan if you still have ability to change the plan, modify the step if you have the graph already, so modify the patients or have to prepare or counseling the patient for that problem to be happens. For next step for the patient preparations, I think because it is all the surgical patients, so we have a time to optimize the patient to minimize intraoperative and post-operative complication, unless there is no time to do. In terms of comorbidities, because these look like less injuring procedures, but not that low physiologic burden to the patients. With some hematologic disturbance, with renal complications, a lot of things can happen. And also the operation is not so short. Sometimes the operation time is quite long. And also we prepare the patient for potential complication issue. One thing is very important for this extent of the repair is spinal cord ischemia. We can do the stage of the procedure. We can set the repair like a staging aneurysm sac exclusion. You can do in two ways. You can do the sequential aortic coverage with the TEVA and then fever and distal component, or then fever and another section of the distal components, or with the sequential flow exclusion by temporary sac perfusions, like a special branch for that, or you leave some branch open for perfusing the sac, and then or another option is to incomplete components, and then you can do it later. But it depends on the logistic issue when you can get back the patient to finalize the procedure, which one is a bit easier. And when you have consider that the patient needs some staging like that, you need to prepare the patient in the state fashion to do the TEVA and then schedule for the next step of the procedure. That should be in the optimum time to prevent some ruptures that can happen during the staging. And we do to do the preparation of the access. If the patient have a bad access, you need the access preparation with the conduit. So in the past, we just go into the operation directly and do the conduits and do the procedures that may prolong the operations. And this will be a bit beneficial if you can do the stage access preparation. You can do just only the ileophane bypass, and then the next step, just access to that bypass graft. That will prevent the bleeding while the patient being on anticoagulation therapy during the procedure. For the implantations, a lot of things can help to go through the procedures. For me, if you have available technology, so I will start to do the 3D fusions, and most of them, not just a fancy thing, but it can help to reduce the radiation and also the contrast media to be used, and so shorten the operative times. For me, the technique I prefer will be 2D, 3D registration, if possible, because this decreases the radiation exposure, and then to calibrate the fusion mask later to guide our the whole procedure later. And then keep the heparins being adequate. Heparinization, especially when you go to the branch, to prevent the desembolization or also the neurological complication of the arch embolizations, and maintain the hemodynamics above 80 or 70 MAP, and then adequate volume resuscitation and low threshold for transfusions. And my preference is to selectively use the prophylactic drains. For the access, for the femorals, I always go with the percutaneous access pre-close or glide, and you can downsize the access as soon as possible to allow lower limb perfusions. For the brachials, I almost always come from the arms, the right arm, unless you have a mid-arch disease, because it's more economics and quite a bit easier for me to manage, and also less radiation exposure also. For me, I would go with the high brachial artery near the axilla with the 12 French sheet, with the telescopic 7 or 8 French sheet down to the target vessel we are treating. We start with the punctures and then close with the cut down later. This will prevent the bleeding or the slipping of the sheet during the operations, and also less exposure to less bleeding at the access site also. And also one thing is to allow distal perfusion of the arm. You don't have to control if you have some bleeding around the sheet. For just a simple branch procedure, like a single branch or two closure the branch or do the reintervention, I do the brachial access at the elbow. It can be compressed later. For the axillary transacted access, the percute large sheet with the second part, I tried some of them, but mostly they need some backup with covers and later is lack of the stock, so we skip doing this for a while. And then remember just to pass the arch only when the patient get the full heparinization only. This is my preference. Come from the right arm, go to the mid arch and use just a copper catheter to go into the descending aorta, and then change to the zip wire and then follow with the 12 French sheet. This happens later after heparinizations. The alternative route access that we are looking for is the cerebral sheet. That will allow us to do everything from transfemoral approach. And then introducing the device, just a series of dilatations with the cunnilators, with orientation, with the markers. With the side branch, I think that we know a problem for the new generation surgeon have a skill for that, and then do the branch. If you do from the arm, do from the branch, start with the branch below first to avoid some conflicts and also obscure the field. For the femur, that do transfemoral, start with uppermost first. And then prepare for some strange and some unexpected situation, like a stuck wire with the wear resistant feelings or wear stent configuration. So just think about the thing can happen later and brace for that impact for sure. And for the cone beam CT, it's very important adjunct to the procedures. With this one, you can see in this patient, you can see some few things happen because it's stuck with the bridging stent collapse. That will be missed by just only the compression angiography. So and the final for the surveillance. So I think it's based on the patient first postoperative CT. If there is no endoleaks, I will do the patient with the follow the patient with the duplex scan and the 4-wheel plain film KUB or even the TL spine film, even if we repair the thoracoabdominals. If the patient gets stable sac size, for sure every 6 months. If the regress sac, it can follow longer with 12 months. Whenever the patient have the enlarging sac, so we get the CT, or even with a questionable sac enlarging or not, we start with the non-contrast CT first. If we confirm the sac size, and then we can follow with the CT if enlarged. With the type 2 endoleaks, also more the same. The sac size is an important thing to follow. Also with the plain film to see the stent configurations. And then if something happens, we are not reluctant to start with the CT. But if not really necessarily, it's just questionable, start with non-contrast CT first. For the type 1A, the type 3 endoleaks, just with reintervention and follow as a postoperative period. And this because we do more complex thing and more complex complications you will see. This for if we see this in the past, we don't think about the leaking from the branch. We don't know exactly how to manage. And then for more complex procedure, you have to think about what you have done before, and then have to select all the branch. And then we see the one seen door leaks that will be a bit easier to fix with just balloon dilatations. And there's also the one seen door leaks in the branch procedure also. And this is a little bit weird things with the endo leaks that you cannot identify the leaks that come from the branch, directly from the branch, and disappear when you reline the branch. So it depends on what you have done earlier in this patient. So in my summaries, I think the complex EVAR is feasible for nearly everyone of the surgeons, but however, it requires some critical planning process, not just only the planning of the graft. And it needs instrument and some inventories that most of them facilitate the procedure, not just fancy things to do. You need a team to help you a lot in these complex procedures. You have the structure, follow-up protocol, and also the complication management strategies. And also the most important thing will be the learning curve. Not just to do the operation, not just to implant the stent itself. It's learning curve to deal with the complication and the unexpected situation that you may face later in the case. Thank you very much.
Thank you very much, Dr. Kiattisak, for a very nice step-by-step for the approach of this quite difficult situation. I'm not sure our panels have any comments or any questions.
I have a question that in case that we did the EVAR or TVAR and then have the problem, but like for the CT surveillance, and we found that like the aneurysm sac is increased, but we cannot see the leak, which normally we call endotension. So how can you manage that case?
I think when you face endotension, basically, and most of them are the hidden endoleaks, you have to look everything for the patient. Let's say you have to look at the configuration of the stent, because sometimes it expands and doesn't contact to the walls, but the endoleaks didn't clearly seen on the CT scan. Probably sometimes it just less sensitivity. So I'm not reluctant to send the patient for diagnostic angiography. And then if you still cannot identify any source of endoleaks, I think the recommendation by the next thing will be totally relinings of the old graft. But it depends, because if you reline the whole graft, the sealings happens and or occur according to the old graft that outside. So nearly of them end up with the proximal repair in it.
What about the spinal cord ischemia? You mentioned that we have to consider the drain. When are you suggest that you do the complex procedure, let's say? When do you suggest that we should consider this problem?
Look at the patient first. If the patient has some risk factor with the PAD, with old patient, or with the previous aortic repair, and with the new extent of the repair is higher than retrocardiac regions, or 4 to 5 centimeters above the celiac trunk, I prefer to put a spinal drain. But I think this issue is a logistic issue according to the hospital policy also. If you can get the patient to get the drain in time, if the neurological symptom happens later after operation, you can just follow as a like on-demand draining. I think it depends on the logistic issue also.
Well, thank you very much. Dr. Sun from Vietnam will also share this issue with us later this morning. Well, thank you, Dr. Kiattisak, for a nice presentation.